This is Dr. Ihab Abdurrahman Ihab Tarawa, consultant for acute care medicine at Soba University Hospital, professor of medicine, University of Khartoum, dean of Sama Institute of Health. We are still doing our sessions in basic emergency care course. This is about shock, secondary survey, and here we would like to discuss secondary exam finding. We mentioned the objectives to recognize signs of shock and poor perfusion, perform critical action for patient with shock, how to assess fluid status, select appropriate fluid administration based on patient age, weight, and condition, recognize malnutrition, anemia, burn, and adjust fluid resuscitation accordingly. Remember that shock is tissue hypoperfusion. Shock happens when there is no enough delivery of oxygen to the tissue. Patient with shock have a feature of sympathetic surge like tachycardia, tachypnea, sweaty, and initially the blood pressure can be maintained because this is a compensatory phase. At this phase, you can see the hypoperfusion in the brain from confusion, irritability, low urine output, and cold climb extremity. Later on, when it becomes decompensated, then blood pressure drop. So low blood pressure with poor perfusion is a very bad sign. The initial ABCD approach is to identify and manage life-threatening condition. Whenever you find a problem, fix it before you move to the second phase. While in secondary survey, we look for changes in the patient condition and less obvious causes that might have been missed during the primary survey. Remember that you have done the ABCD and fixed the life-threatening condition. In secondary survey, if you identify a life-threatening condition, you need to stop and go back to the primary survey. Secondary exam finding. Look for breath sounds and respiratory rate. Abnormal or noisy breathing can indicate pneumonia. High sugar level can cause chemical imbalance in the body, and this lead to DKA and acidotic breathing. Sweet or fruity smelling breath can point to hyperglycemia and DKA. Look for bleeding. All external bleeding should be controlled by direct pressure. Also consider vaginal bleeding or even concealed bleeding. Check fluid status, assess dehydration. You can see dry lips, dry tongue, dry mucous membrane, and patient also might complain of or feeling thirsty. As we mentioned, dry lip, mouth, and abnormal skin pinch, lethargy, and delayed capillary refill. Shock can happen in the background of fluid overload, as a patient with heart failure and fluid overload, a swollen leg and crochial and raised JVP. But when the relative cardiac filling is reduced, then can go to cardiogenic shock. So this is a difficult situation and it needs careful assessment and management. You need to look at the conjunctiva, and you can see pallor in the conjunctiva, which can indicate anemia and blood loss. Mental status, patient can have irritability, confusion, which could be due to tissue hypoperfusion. Change in mental status can happen also with hypoxia and with hypoglycemia. And if you are suspecting hypoglycemia, don't forget to use glucose load to correct that. Fever can happen and can give you clue to that, to sepsis. Patient with severe abdominal pain, this could be due to intra-abdominal sepsis or intra-abdominal bleeding, as in rupture ectopic pregnancy. Urine, when it is cloudy and it is burning, it can suggest sepsis, and also dark urine and small amount can happen in dehydration. Patient with malnourished patient require a specialized rehydration plan. Be sure to check about recent weight change. And patient with allergies, they can present with skin rash, hives, swelling on the lip, tongue, and even in the airway with stridor. Um, and exposure, they can have exposure to medication or insect bite or any new allergen. So after you do the sample history and you do the thorough exam, you wanna figure out what are the possible causes of shock. Infection, patient can have fever, tachycardia, tachypnea, hypotension. Here, shock, when it happens in sepsis, they call it warm shock. Instead of warm, instead of cold and clammy extremities, they can have warm extremities. And you can have obvious source of shock like pneumonia or abscess or feature of urinary tract infection. Those with spinal cord injury, they can have history of trauma, tender in the spine, lack of alignment of the spine, presence of crepitus, and they can show neurological deficit by loss of motor function and loss of sensation and bladder control. Some they can have periabism. Those with spinal shock can have bradycardia and hypotension, and sometimes difficulty in breathing. Those who have allergies, they can have swelling in the mouth, difficulty in breathing and stridor, rash, tachycardia, and hypotension. Those with DKA, diabetic ketoacidosis, they have history of diabetes, rapid and deep breathing, cosmal breathing, frequent urination, polyuria, sweet smelling breath, and high blood glucose and dehydration. Severe dehydration, there could be history of vomiting, diarrhea, excessive urination, and you get tachycardia, tachypnea, normal or low blood pressure, dry mucous membrane, and and abnormal skin pinch. Those who are exposed to burn, you can see red, white, or black area depending on the depth of the burn, and they may have blisters, and they can have also inhalation injuries that lead to airway compromise. Burn injury can cause excessive fluid loss through the damaged skin. Patient can have external bleeding because those with trauma, you can see obvious bleeding and could be active. And especially those with fracture in the pelvis or humerus, bleeding can be a large amount of blood can accumulate in the thigh or in the pelvis, and this could be concealed. And patient with bruising around the umbilicus and in the flank, that can happen with necrotizing pancreatitis, abdominal pain, and very firm abdomen, this with intra-abdominal bleeding or rupture ectopic. Blood can coming as hematemesis in the vomitus or in the stool as melena or hematochezia. History of alcohol use can lead to portal hypertension or gastritis. Patient with trauma can have a hemothorax. They present with difficulty in breathing, decreased breath sound, and dullness on the affected side. And the thorax can accommodate a significant amount of blood that lead to shock. Ectopic pregnancy, the patient could have a history of pregnancy or she just missed her cycle, and they have abdominal pain. Sometimes they have vaginal bleeding, but it could be absent. All bleeding could be in the abdominal cavity. Postpartum bleeding can happen after recent delivery. It could be very heavy. Those using pads, they have sometimes change it every 5 minutes, and there could be continuous dribbling of blood. And after recent deliveries, uterus could be soft and lax. Those with heart failure, could be difficult to diagnose because of the volume overload, lower extremity edema, crackle in the lung, distended neck vein. But feature of hypoperfusion that manifest as altered mental status, cold clammy extremities, and low urine output can give you a clue. Because in spite of fluid overload, they can have relative intravascular volume. And sometimes you need help from a senior and expert to identify this cardiogenic shock. Those with heart attack can present with chest pain and cardiogenic shock, and also at the same time they can have pulmonary edema. Arrhythmia can precipitate also cardiogenic shock. It could be atrial flutter, atrial fibrillation. Those with cardiac valve abnormality, they can present with cardiogenic shock, and they can have a murmuring examination plus feature of pulmonary edema. Pericardial tamponade, consider that in patient with trauma. It can happen in patient with renal failure or a malignancy or TB. Patient have tachycardia, tachypnea, hypotension, pale skin, cold extremities, and capillary refill is prolonged, distended neck vein, muffled heart sound, and they might have dizziness, confusion, and altered mental status. Tension pneumothorax can happen in the background of trauma. Patient have difficulty in breathing, absent breath sound, and hyperresonant percussion note, distended neck vein, plus other feature of shock. Hypoglycemia can mimic shock because it presents with altered mental status. Patient can be sweaty also because of sympathetic surge, and can have seizure and convulsion. And usually they have low blood pressure, low blood sugar. Whenever you suspect hypoglycemia, you give check the blood glucose. If this is not immediately available, you can give glucose load. This can happen in patients with malaria and severe infection. Take home when you are doing the secondary survey in patient with shock or suspected shock. After you do the ABCD approach, you go through sample history, then you elicit feature of tissue hypoperfusion. We check that on the brain, in the kidney, in the skin. Shock can happen with normal blood pressure. Drop of the blood pressure means that the tissue is no longer able to compensate. In the secondary survey, you want to assess the volume status. You want to assess for blood loss, external or internal blood loss. Look for feature of sepsis. Look for feature of trauma, because this can lead to shock because of blood loss to the outside, external bleeding, or blood loss in the chest, hemothorax, blood loss in the abdomen, in the pelvis, in the femur, or even spinal shock. And don't forget cardiogenic shock, and it needs careful assessment. Thank you.